The voice, Neil W. Swinton of the Leahy Clinic Foundation Surgical Department and president of the American Proctologic Society, introducing a panel discussion at the Society's 68th annual meeting in Boston.
It's particularly the case in a multi-specialty group like our own that we have experts in almost every line available, that in running our training programs, we're trying to give these young men the best education that we can. I like in my own service to take full responsibility as a colon rectal surgeon for the preoperative diagnosis, evaluation, pulling in consultants as we need them, working closely with our residents, which is where they learn, and getting these patients up to surgery and through surgery with the lowest possible mortality and morbidity. And our panel are men from our group that have been at this for a long time, and what I want is to give some ideas on how this can be done.
And during this next hour, you'll hear all the ideas expressed by the panel concerning the preoperative evaluation of the colorectal patient on Audio Digest Surgery, Volume 16, Number 15, for the week of August 13th, 1969. And to begin, here once again, Dr. Swinton in his role as panel moderator.
Our first speaker is Dr. Robert Wise, who's chief of our Department of Diagnostic Radiology. And I've asked Bob to point out some of the pitfalls that can be made in X-ray diagnosis. We have problems with patients coming in with films that have been taken outside. Do we need to repeat them? How can we work with him in not only the preparation of these patients for X-rays, interpretation, and other points along that line? Dr. Wise.
As far as films from the outside are concerned, I think this can be handled very simply. If the films are adequate in our judgment, we simply do not repeat them. There is no need for it. If they are inadequate, we forthrightly say so, and the examination is repeated. Now, I think perhaps this will give me a good chance to speak to my colleagues here without being interrupted, and perhaps say a few of the things that I've been saying to them for the last 16 years, many times being interrupted in the process of it. Dr. Swinton has alluded to cleansing. This is probably the greatest problem, or one of the significant problems, that we face in the examination of the colon and the detection of diseases of this organ. The evidence is probably incontrovertible that the incidence of missed lesions will rise with poor preparation. It doesn't really matter why the preparation is poor. Our job is not to blame, but our job is to prepare the colon. Whether this is a matter of sympathy on the part of the referring physician for his patient, whether it's inadequacy on the part of the radiologist to insist on it, whether it's the reluctance of the patient to take the preparation, whether it's negligence of physicians, really makes not the slightest bit of difference in the last analysis. For it remains true, the poorer the preparation, the higher will be the incidence of missed lesions. There's therefore a dual responsibility here. There's a responsibility on the part of the clinician to act responsibly and prepare the patient to the best of his ability. There's a responsibility on the part of the radiologist to guide and insist that this preparation be as good as is humanly possible under the circumstances. It's perfectly obvious that all patients cannot be prepared ideally. Many times it's dangerous to prepare the patient. Many times it's inconvenient. Many times the patient refuses to cooperate. But whatever the reasons are, our aim certainly must be to prepare this patient. Now, as to the technique of preparation, there probably is no really good form of preparation. I will not get into the various types of laxatives, but I do firmly believe that a laxative should be given whenever possible. Unfortunately, we're limited by the physiology of the patient many times. I have some very good control studies where we have clinicians who have religiously followed our advice with the various types of preparation, with the various laxatives, and I have clinicians who have rigorously resisted all recommendations toward this end. Without any question, the preparation is better in the man who was cooperative, but it is far from perfect, and I recognize this, and of course, I am sure that you do as well. I would like to make one point about the philosophy of doing a barium enema, in addition and beyond preparation. Many times the excuse is used that, well, he really doesn't have anything, I'm quite sure, I'm just doing this to prepare the patient. I will leave the question, the answer, the judgment of the honesty or dishonesty of this approach to this audience, but I think my implication and inference is quite clear here. But what are the other reasons that we might miss lesions? Failure to obtain the proper views. There's no question about this. If we don't do the job properly, if we don't have the technical know-how, and if we don't have the will and drive to do it, we are simply going to miss lesions. If we have a poor radiographic technique, we're going to miss lesions. If we select our kilovoltage improperly, for instance, we're going to miss lesions. If we have inadequate equipment, we are going to miss lesions. There is no question in my mind but what image intensification is here to stay. I realize that there are few radiologists who do not share this opinion for one reason or another, and the reasons are unimportant, but the vast majority of radiologists today, I'm quite sure, insist that image intensification is the sine qua non of proper examination of the colon in the future. I cannot recommend it too highly. As far as our technique and selection of procedure is concerned, I think we might say that the routine barium enema generally is inadequate for the detection of the small lesions, that is the polyps of the colon. However, a combination of the routine barium enema with a high kilovoltage technique will obviate some of this deficiency. Beyond that, it is our feeling and my conviction that the air contrast study is probably the best examination in the long run, considering the fact that the colon cannot be adequately prepared many times for the detection of polyps, and this I do recommend. Dr. Swinton and I have long held to the principle that a single air contrast examination which shows a small, rather atypical polyp is inadequate and improper indication for surgery. We insist that unless the appearance of the polyp is absolutely classical, with a stalk and so forth, that a single air contrast examination is inadequate. This is our means of eliminating, insofar as possible, the false positive diagnoses which creep into our practice. Now that I've berated my colleagues, I think that I could sum up my position as to where the true responsibility lies, touch upon something that Dr. Swinton alluded to in his introductory remarks. In my judgment, and I would like to leave this message with you, if any, regardless of the poor preparation of the patient, regardless of why it occurs, regardless of the improper films, whether they be made by a technician or not, the true responsibility lies here with the radiologist, and it is the competence of the radiologist in the last analysis that will make the diagnosis. Now, Dr. Swinton said that in his section of proctology, they wish to assume the responsibility for this. It is interesting that both disciplines wish to assume this responsibility, and I think that perhaps out of this cauldron will finally come the answer of what we feel is a proper way to do this, that is the team practice of medicine. I would like to touch for a moment on the future, and what the future holds in the way of examination of the colon and perhaps improving our diagnostic accuracy. We should probably exert greater group control in some fashion or other over the preparation. Perhaps there has been too much individualism in the preparation of these patients. We must have adequate history, and I cannot stress this too strongly. History will improve the diagnostic reliability of this study beyond any question. It is improper to say that we are only playing games with a radiologist. Why should we help him? Whatever the myriads of excuses are, I'm too busy. You name your own excuse, and I think we can find them all invalid. Beyond any question, in my judgment, proper history to tell us where to look, not only to save us time, but to assure that we will then search out the area in question, is again the sine qua non of good examination of the colon. Now, aside from all of this, once all of this has been done, proper enemas, good radiologists, good cooperation on the part of our colleagues, what does the future hold? I think it holds angiography. If we are unable to detect the source of the melena, there is good enough evidence now that the patient should be subjected to angiography, for many lesions can be found today by angiography that simply cannot be found either by the radiologist doing conventional procedures or by the surgeon with the abdomen opened. I strongly recommend that if one cannot find the source of the melena, that we go to angiography.
Our next speaker, Dr. Warren Nugent, who is from our Department of Gastroenterology, is going to talk about blood volume, problem of steroids, antibiotics.
In order to make this discussion a little simpler, I have conjured up a patient who is a 45-year-old male with chronic ulcerative colitis and an acute exacerbation who is febrile, who has lost 30 pounds in the past 3 months, whose hematocrit is 34. Now, the first step that we're going to take in this man is to think about his blood volume. If we are to transfuse this gentleman with a unit of blood, we would expect a rise in the hematocrit in the range of 3 to 4%, and we would then have a hematocrit of 37 to 38, which is borderline and actually a little low for a 45-year-old male who might be expected to be more in the range of 43 or 44 or better. Now, if this patient goes to surgery in that state, one can anticipate a much greater morbidity and mortality than we would see if he had not lost the 30 pounds that he had in the preceding 3 months. There is a good deal of experimental evidence, both in animals and in human beings, that a contraction of the blood volume accompanies weight loss, and this is in direct relationship to the acuteness of the weight loss. You have all experienced the situation where you would transfuse such a man and see a unit of blood bring his hematocrit to 37, and then give him another unit, and it's still 37, and give him a third unit, and it's still 37, much to your surprise. And then you might even pursue this and give him a further one, and all of a sudden it jumps to 45. This is simply another way of doing what I'm going to suggest a formula for. What we have done is to transfuse these patients to a low normal, in other words, to the range of 36, 37, or 38 hematocrit. And then we estimate the blood volume deficit. And this, if you wish to check with doing blood volume studies, you can find is really very accurate. We give them 40 cc's of blood per pound of weight lost below their estimated ideal weight. And then we take into consideration the time relationship. If the weight has been lost in 3 months prior to surgery, we give 100% of this estimated deficit. If it has been lost in a period of 3 to 6 months, we give 50%. And in a period of 6 to 12 months, we give 25%. And we might be dealing with combinations of these if the patient has been sick for a period of 6 months or so. So then you have to sit down beside the patient for a minute and decide on his ideal weight, over what period of time he has lost this weight, and so forth. Now, our hypothetical patient had a 30-pound weight loss below his ideal weight. We would therefore assume that after we had given him his first unit and brought his hematocrit to 37, that we would then give him 30 times 40, which would be 1,200 cc's of whole blood. And our practice is to play this just a little light and give him the 2 units, and then we feel that he is ready, blood volume-wise, for operation. I will repeat that there is adequate evidence, both in the animal laboratory and in humans, that this is necessary, and that the tendency of shock under anesthesia with all of the complications that go with it, such as invasion of the bloodstream with bacteria and so forth, is remarkably less if the patient has an adequate circulating, effective blood volume when you take him to surgery. Now, all of the patients that we see who have been taking corticosteroids, and our patient with ulcerative colitis had been, are hooked, as to say. And if we see the patient as a new referral and he has to have his colon resected, if he's been taking steroids within 6 months or perhaps even 12 months, depending upon the dose and the length of treatment, then we must prepare him adequately with steroids. Cortisone acetate is probably the best to use if one has a little time. And our plan is to use 100 milligrams every 12 hours the day prior to surgery, 100 milligrams every 8 hours the day of surgery, and 100 milligrams every 12 hours the day following surgery. Then one has to taper it depending upon the course of the patient and the stress that they are under. If it's a smooth course, one can cut down very rapidly. If it's a complicated, febrile, infected course, we have to be a little more cautious. We also have to keep available at all times 100 milligrams of hydrocortisone to be given intravenously. If the patient who has intramuscular steroids goes into shock, he may not have adequate absorption. The one rule that perhaps can be said about the patient who has been on steroids and on whom you have to give steroids is that you can never give too much over this short period of time. It's possible to give too little, but it is almost impossible to give too much if we're dealing with a period of simply 2 or 3 days in the operative area. Now, this patient was also, as you recall, febrile, which means that with his ulcerative colitis, he not only has mucosal inflammatory change, but probably what amounts to a cellulitis of the bowel wall. In other words, we have here infection that cannot be reached by intraluminal antibiotics. And it is our practice to give all of these patients systemic antibiotics. Now, I realize that there will be arguments probably on this score. But in our hands, we have had much more success with decreasing the morbidity due to infection and the mortality, which is very serious in these patients, by using some type of antibiotic scheme and beginning it about 24 hours before surgery. Our present choice of antibiotics in the patient with an infected colon is Keflin. We give 2 grams every 6 hours, which is a total of 8 grams a day, piggyback in their IVs beginning about 24 hours prior to surgery. To this, we usually add ampicillin, 500 milligrams 4 times a day intramuscularly, again beginning the day prior to surgery. Ampicillin covers the range of anaerobes that Keflin does not cover. Now, there are alternate programs. Some people use large doses, 20 to 30 million units of penicillin, and I have no objection to this. We feel that the one thing you must do is avoid doing harm to the patient, and secondly, one must try to control the problem of infection. We have found Keflin to be uniquely free of side effects, particularly as far as the kidney is concerned, and we have found ampicillin to be an extremely helpful adjunct, again, particularly in the area of the anaerobes. I think it is important on all of these patients to get a culture from the peritoneal cavity at the time of surgery. You can always get a half a cc of fluid of some kind, so that in the immediate postoperative period, we are now able to judge the bacterial problem with much greater accuracy when we have our bacterial cultures and sensitivities. Now, there are many other factors that must be considered in this hypothetical patient of ours. Many of these patients have had oral antibiotics. They have had malabsorption of one degree and another. They have not eaten adequately. One has to think of such things as adequate vitamin K absorption in the period prior to surgery, and every once in a while we are shocked to find our patient bleeding from hypoprothrombonemia. So this should be an absolute routine of checking the prothrombin time and giving it muscular vitamin K if there is any question whatsoever in the preoperative period. I'll not try to get into the problems of fluids, electrolytes, proteins, and so forth, except to say that as you replace their blood volume, you are also replacing, in part, the protein deficits that they will have.
Now, our next speaker will be a member of our Department of Urology, Dr. Joseph Dowd. All of you, whether you do hemorrhoids or whether you do colons, have genitourinary problems after operation. And certainly we've learned with a proper evaluation, a great many of these can be prevented. And that is the subject I've asked Dr. Dowd to cover primarily.
What is it that the colon and rectal surgeon could do to keep the urologist happy? Without wanting to show my paranoia too blatantly, I'd like to say, first of all, that surgeons in general tend to disregard, at least during working hours, the urogenital tract. They disregard it at least until there's a problem, and then they usually want a prompt and total solution. Davis's revised edition textbook of surgery, which I understand is the largest seller of undergraduate students in the medical schools in this country, like its predecessors, still barely mentions the urogenital tract in the preoperative evaluation of the patient coming to colon surgery. In a group setting such as we happen to have, and especially during the first 2 months of the resident hospital year, July and August, we would like to be called to see folks who are coming to colonic surgery. Or, if failing that, it would seem well for them to reflect and ideally to record the following information. In examining the patient, it's well to find out by history factors related in 3 categories: things that are related to their colon and rectal disease, the factors that may reflect obstruction, the common problem, or things that are chance findings. And the things related to colon and rectal disease, pneumaturia, how often we forget to even ask, are the suggestive pericolic inflammations with irritable bladder symptoms, or where there's a sphincter problem, anal or urinary, with very low-lying anorectal lesions. The site of their pain, whether it's flank, abdomen, thigh, or penile pain. Penile pain is commonly the first symptom of an eroding vesico-colic fistula. And if there's been a fever, and particularly if there's been decent response to the treatment of this fever. The obstructive symptoms are pertinent primarily in the male, whether they have hesitancy, whether the stream is decent in force and size, whether they have a sense of decent emptying, whether they get up at night, or whether it's just nervous daytime frequency, and what has happened to them if they've had anesthesia or enforced bed rest in the past as regards voiding. And the chance findings in general could be well covered by a few questions relating to whether they had ever had blood in the urine, or been told they had a stone, or a significant fever, whether they have a chronic back pain, whether they've ever had to be catheterized in the past, or been told in some physical or an insurance exam whether their urine or kidneys were abnormal. And on physical examination, whether you can find a mass, incision, or tenderness in the flank, the groin, suprapubic region, or perineal area. Examining the external genitalia, the foreskin may preclude a necessary urgent catheterization, or the condition of the meatus, which is not infrequently stenotic, whether there's a hernia, taking a ball count, and if possible, for those who don't have the bashful bladder syndrome, observe the voiding stream. On rectal examination, although there's probably already, if it's a referral from the colon and rectal service, been a lot of traffic there, we would like to do our own rectal examination, or at least to have recorded its relationship of the mass to Denonvier's fascia that covers the rectoprostatic barrier. Particularly noting the size of the prostate, its resilience, whether there are nodules, and if possible, a simple sketch in the margin. As for laboratory notes, the urine sediment is important, whether there's albumin or not, sort of a red armband as a herald of whether there is significant urinary disease, renal disease. It's of interest that we find a very significant number of our colleagues, and particularly residents, getting frequent electrolyte surveys, axillary zinc, inguinal uranium, with a startling avoidance of recording an occasional blood urea nitrogen, or preferably a serum creatinine. Obtaining a urine culture, if it's positive, suggests that it may be related to the colon rectal disease or some obstructive phenomenon, or purely the chance finding. But at least you have recorded a baseline in case there's bacteremic shock and very urgent vital information is needed. We would suggest an intravenous pyelogram, certainly on all males over 45, particularly if they're going to be coming to abdominal perineal resection. And if the facilities are available for reliable Papa-Nicolau smears, we would certainly get them on anybody with a history of hematuria, or even a few red cells in the urine. If there's any symptoms related to their colon and rectal disease, and if there's been any positive physical findings. Now, do you have to delay your operations just to get an intravenous pyelogram? A few months ago, Dr. Janowitz and his group from Mount Sinai in New York had a very worthwhile contribution to the literature in their provocative paper about the abnormalities on excretory urography in people with granulomatous disease of the colon. We don't, of course, suggest that you get an intravenous pyelogram on everybody. Often your surgery is urgent, and to delay it for an intravenous pyelogram without some other significant reason is unnecessary. For reasons of allergy, you may not be able to get it. Inability to get a half-decent bowel preparation. For some of these people are distended, occasionally obstructed, and often they're barium impregnated. But if there are no signs or symptoms or abnormal laboratory findings, and the patient is not a male coming to a Miles resection, it is not absolutely essential that you get an intravenous pyelogram, though we're always happy to see it. Janowitz and his group from Mount Sinai's paper was certainly interesting to us. I think it reflected more their sick patient population and a little bit of an unusual experience, at least from our point of view. Although we did have in our group a few extrinsic obstructions, Dr. Shen and I have reviewed two sizable groups of people who came to pyelograms. In the first group, those who had granulomatous disease of the colon, we had but 2 of 48 people in recent studies, or about 4%, who had sufficient retroperitoneal inflammation to cause extrinsic ureteral obstruction. And in these two instances, it was certainly no surprise. They had fever and flank pain. Now, in the second group of 100 people on whom we had pyelograms preoperatively, on folks from Dr. Swinton's service, we had a significant number of other findings. Now, this series is probably a little bit loaded because we only did them on those who had some historical, physical, or laboratory abnormality that suggested that a pyelogram would be helpful, and also on everybody coming to a Miles resection, at least every male. And what we found in 100 folks, 24% there were changes in the pyelogram related to their primary colon and rectal disease, a ureteral distortion, or a bladder displacement, or inability to fill it out completely, and so on. A significant obstruction was found in 19%, and this figure looks tiny, but it really isn't, for remember, half of these people are females, and obstruction rarely is a major factor in their course. And so 19% is probably closer to 38 to 40% of people who had, coming to Miles resection, had significant obstructive stigma on their preoperative study. And the chance findings, usually some anomaly that may be significant, a high incidence of oxalate and uric acid stones, past trauma that may not be significant but causes a distortion on the pyelogram.
Pardon me, gentlemen, for just one moment, to say that this doctor concludes this side of your reel. On side B, the continuation of this program on the preoperative evaluation of the colorectal patient, heard by simply reversing the two reels or cassette on your tape recorder. Continuing a program on the preoperative evaluation of the colorectal patient, this is side B, Audio Digest Surgery, volume 16, number 15. Neil W. Swinton, our panel moderator, resumes the discussion with these words.
Now, our next speaker will be from our Department of Cardiology at the clinic, Dr. Sidney Alexander.
This is a subject I feel very evangelical about. This is an area in which the surgeon, despite his hundreds of years of training and his advanced technical skills, often seems to overlook. And as surgical skills increase, and as surgery, particularly extensive elective surgery, is brought to a greater and greater audience, it's my firm belief that largely your mortality rate, particularly in the older population, is going to be determined not so much by the operation you do, but in whom you do the operation and how you take care of him before and after operation. And largely this is going to be determined, that is the surgical risk, by what kind of status his heart is in. And I want to emphasize particularly today the patient with arteriosclerotic heart disease, because this is going to constitute a large portion of your patient selection, and it's the kind of thing that the surgeon often isn't tuned into. And I think it's important that we begin to emphasize which patients you can, which patients you cannot operate safely on. How often have you asked the internist, I hope you all have, what do you think the risk is in a given patient? It's something that every good physician does, and supposedly the internist, and even more the cardiologist, is supposed to know the answer to this. One of the things I want to emphasize today is that most of what he answers is his own subjective opinion. Many of the statements made are utter nonsense, and in actual fact, we have very little knowledge, really good facts about what constitutes surgical risk. This thing has been bandied about so much in the literature, and particularly on the wards, that I became interested in finding out just what is surgical risk in patients and what constitutes it. It becomes quickly apparent that in these studies, that in patients who have had a previous diagnosis of arteriosclerotic heart disease, the mortality rate of the cardiac patient is far greater than the mortality rate of a comparable group of patients in whom no diagnosis of heart disease has been made. And if you contrast the mortality rate in the non-cardiac patient versus the mortality rate in the cardiac patient, the answer becomes obvious. We are often asked another question: how soon is it safe to do surgery in a patient who has had a previous myocardial infarction? Well, there is surprisingly little data in the literature on this, but what can be collected does show that the mortality rate is enormous in people who've had previous myocardial infarctions, and we have some here that go as far as 6 months. One of the old saws that fills the literature is that since most internists consider the healing period after a myocardial infarction to be 3 months, this gives the surgeon carte blanche to do anything he wants to this patient in an elective manner at the end of such a period. And most internists use this rule. Well, I think this is on very shaky ground. If you, again, review the literature for hard facts and not just personal opinion, you begin to see that for elective surgery, the mortality rate, and I mean purely elective surgery now, the mortality rate for patients with arteriosclerotic heart disease after a myocardial infarction does not begin to approach anything near the mortality rate for his comparable age group for a year or two after surgery. And that's certainly waiting just a few months for elective repair of something or other. You are exposing this patient to a markedly increased risk. Most of these people die, surprisingly enough, for reasons that are not known. We've discussed surgical mortality rate, and by the way, this is general surgical mortality, of course not just colon and rectal surgery. I think the same thing applies. It is amazing that despite the fact that we are beginning to get some inkling that these patients die, no one has the foggiest notion of what they die of. Now, it seems reasonable to me that if patients with heart disease die in greater numbers than patients with no heart disease, and if they are being given the same operation, the difference in the mortality rate is very likely to be due to the reaction of the heart to the stress of surgery. We're not certain of this. This is something that we are actively trying to answer right now. But in a patient who has had a previous heart attack, who has a heart attack post-operatively, the mortality rate is extremely high. If you take the incidence of myocardial infarction in people who have no previous history of heart disease, it's very small. The incidence of myocardial infarction in people who have had previous myocardial infarctions, that is post-op myocardial infarctions, is very high, and the mortality rate is also very high. Surgical risk in patients with non-arteriosclerotic heart disease is pretty proportional to their functional cardiac status, and anybody can find that out. All you have to do is walk up and down stairs with a patient or ask him some very simple questions. The patient with arteriosclerotic heart disease, particularly those with recent myocardial infarction and those with unstable angina, and this is something that you should ask in your history, not necessarily how severe the angina is, but is it stable or is it unstable? Is it becoming progressively more severe? These are the patients in whom the risk is very high. Finally, no cardiac problem occurs unless there is gross negligence in patients who are young and who don't have any of the risk factors that make people prone to coronary disease. And I think that all of you should know what constitute these risk factors and should know whether or not any patient you operate on has any of these risk factors, because if he does, then perhaps it behooves you to prevent cardiac deaths in surgery. Before, I said that there must be some cause for the increased incidence of death in cardiac patients, and very likely they die for the same reasons that patients die of after acute myocardial infarction. That is arrhythmias, congestive heart failure, and cardiogenic shock. Seems to me that the high-risk patient, certainly, and perhaps all patients above a certain age group, should be subjected to a standard workup and a standard appraisal, but certainly should be subjected to the kinds of things which I would consider average decent surgical care. By that I mean monitoring of the electrocardiogram continuously from before induction is begun through the operation, and since the incidence of death from cardiac disease after surgery seems to be within the first 48 hours, continuous monitoring for the first couple of days after surgery, and finally to monitor the central venous pressure, which seems to be the best parameter of whether or not a patient can accept the fluid loads you're pushing into him or whether or not he's in congestive heart failure. You know very well that the patient who smokes a lot, whose blood pressure is high, who has electrocardiographic abnormalities, who is obese, whose cholesterol is high, or who has a strong family history of heart disease is a high-risk patient. It behooves you, if you are going to have your best surgical survival rates, to find out who these people are and treat them accordingly.
Our next speaker, Dr. Morris Nicholson from our Department of Anesthesiology, is going to limit his talk to the problems that make them up in the respiratory system.
This problem of the lungs has been with us for a long while, And we're getting so esoteric and specialized, even on this program, that we're dividing the heart and the lungs up. And you know this is an impossibility, because anything that affects the heart affects the lungs, and most things that affect the lungs affect the heart. So I decry people being specialists in the heart and another specialist in the lung. I like to have a guy take care of me who knows something about both of them and how they work together. Now, this problem of lung disease, if we can isolate it, is certainly increasing. What can we do? I think we can be cognizant of pulmonary complications as a major aspect of both medical and surgical morbidity and mortality. We need, whatever our particular specialty is, to establish a mental awareness and be on the lookout for patients with cough, sputum, breathlessness, and those who either, when you listen to the chest or report to you, that they wheeze at times. These are all clear-cut clinical evidences of underlying pulmonary disease, and to differentiate the exact cause, you need X-ray examination and many special studies. Certainly the time vital capacity was easily done, would give you a lot of information. We have to realize that smoking must be equated with bronchitis. Now, doctors should set an example and stop smoking. We're never going to stop patients from smoking while a big fat doctor sits in his office with a belly sticking out, smoking a cigar or a pipe, because the patient says, what the hell, he smokes, why can't I? Now, in contradistinction to what a lot of people think, sex isn't really the American tragedy. I attest to you from day-to-day experience that obesity is the American tragedy. And when you have the other things that I mentioned and the obese patient, this completes the pulmonary nightmare. Well, what can we do in our ineffectual way? First, you can stop smoking and then ask the patient to stop. You can reduce the patient. There are very few patients that I see who have such things as ventral hernias and all this that must be operated on before they reduce. If they won't reduce, let another surgeon operate on them, because he's going to get them into trouble too. We can treat their bronchitis, their bronchospasm, we can hydrate them, we can use humidity even in their homes, we can bring them in, and it's much more economical to give a patient 4 or 5 days of intensive pulmonary preparation before an operation than it is to get him into all sorts of complications and keep him in the hospital another 6 weeks trying to get him out of these complications. We have to realize when we see the obese patient that immediately his diaphragm is pushed up. If his diaphragm is pushed up, this means that he's crowding the basal segments of his lung, and we have definite areas there that are being perfused with blood but is not being ventilated. This means hypoxia, CO2 elevation, and it's undesirable. If they smoke, we know we have a problem of chronic bronchitis. And if they smoke, we also know that they have thick, tenacious secretions which they can't cough up very well unless we hydrate them, expose them to superheated atmospheres with water. Debility means old age, and there's some very good studies to show as we get every 10 years older, the ability of mucus and so forth to irritate our tracheobronchial tree in producing an effective cough keeps falling lower and lower. And advancing age has a lot of other things that set in with it. We know from very good studies, I think Dr. Donald King's observations, which he reported back in 1933 at the Mass General after personally following a large number of post-operative patients, that the problem hasn't changed very much. Most of the post-operative complications come on after laparotomies and herniorrhaphies, especially gastric resections, gallbladder operations, and so forth. They are about 4 times as frequent in men as they are in women. The type of anesthesia in most good studies doesn't really make a whole lot of difference, although I think that if there is much misadventure in the anesthesia, it certainly can precipitate respiratory problems. And you'd say, well, with all of our sophistication and all the monitoring and all the advanced techniques in anesthesia, isn't this problem becoming less acute? I say no, it's becoming much more acute, primarily because our patients are getting older. They're coming to us with underlying disease. Frequently, they're being rushed into surgery. And you must realize that there's nothing now that contraindicates an operation. Old age, extensive cancer, hypertension, kidney disease, we take the kidneys out, we take the liver out, we take the heart out, we take the lungs out. So it's obvious that we're going to get into more and more trouble. And most of these troubles we cannot treat very well, and our only hope for these patients is to be more aggressive and more suspicious preoperatively and try to prepare them better. We no longer let patients die from hemorrhage. We treat their peritonitis very well. We keep their kidneys going. So what do they die from? About 35% of the postoperative surgical patients, I'm talking about people that have intra-abdominal and chest operations and so forth, are dying from a progressive type of respiratory disability. As they become weak, they can't cough, they use more of the oxygen to breathe, they become distended, and they gradually get so weak that they can't cough at all. And even if you had them in a completely germ-free atmosphere, they ultimately succumb to an invasive type of bronchial pneumonia, which antibiotics will not protect them from. Now, sometimes we can get some of them through by doing tracheostomies and taking away the work of breathing for them, but I think we will have to face the fact that if we're going to treat people with extensive disease, not only of their lungs but everywhere, that we're going to lose a large number of them from post-operative sepsis, which is even the organisms that the patient harbors, or the Manila, will become a lethal organism, and therefore you may be discouraged that your recovery room and your intensive care area is not saving all of your patients. It is not going to save all of your patients, but we can prevent some of them from getting into this situation by being more aggressive about diagnosing them earlier, preparing them better, and trying to avoid some of these situations.
A number of interesting and intelligent questions have come in. Dr. Wise has had some questions, and I'm going to ask him to answer his group briefly to begin with.
Has the elimination of the tannic acid barium mixture affected the barium enema adversely? I think that it probably has. Our mucosal patterns are simply not as good today as they were with tannic acid. We are forced by the FDA to use some substitute or nothing. Many people have gone to a compound known as dihydroxyphenylacetin, which is on the market as Levima. It's reasonably effective, but I don't believe it's quite as good as tannic acid. Would you outline the details of the usual preparation for a barium enema? I think there are a number of possibilities here, and rather than get into all of them, I think that some of the variants of castor oil or another preparation, which is a senna preparation, are quite adequate today. I think under some conditions, some patients respond reasonably well to Fleet's phosphorus soda. If these are ineffective, and in particular if we're doing an air contrast enema, we frequently will then do an enema on our own in the Department of Radiology, and quite frequently under fluoroscopic control. I believe that the usual saline enema given on the floor, or the phosphorus soda enema, shall remain nameless for the moment, as far as preparation for a barium enema is concerned, is almost valueless. It simply does not clean out the right colon. It cleans out the sigmoid. If we're looking at the sigmoid, fine, but the right colon, no.
Now I'll ask Dr. Nugent to answer his questions.
The first question is, how long a period of time should a patient have been off steroids before steroid preparation is indicated? Well, I think if you had to pick a time, one would say about a year. However, probably not all patients who have had steroids within the past year need a steroid prep if they have had small amounts and if the time has been longer than a 6-month period, for instance. But if you want to be on the safe side, I think you have to consider a year if there's been any significant length of steroid treatment. And then if they have been in that area, one can rapidly decrease the steroid in the postoperative period. The second question has to do with how soon do you stop steroids post-op in patients with CUC who are going to have surgery. These patients have had steroids for more than 5 years. And that's a long period for steroid therapy. I would first suggest that if you're going to treat patients with steroids, and sometimes you are in a situation where it is necessary, for long periods. We have found in our experience that if you use the medication every second day and allow a day for the adrenal to at least escape partially in between, that one has less adrenal suppression. In other words, if you're going to use 15 milligrams of prednisone a day, instead you use 30 milligrams and give it every second day. And I see no difference in the control of the patient. Now, patients who have steroids for that prolonged period of time must be taken off very, very slowly indeed. Perhaps these patients should have an ACTH stimulation before they are taken off, and perhaps even should have adrenal function studies performed. But I think you'd be talking about a period of weeks. I would tend, personally, to taper them off very slowly and watch them very carefully over a period of many weeks. Perhaps if they were taking 20 milligrams of prednisone a day, I would not cut it down by more than a tablet each month. And if there was any suggestion whatsoever that they were getting into difficulty, I think one would have to stop and do adrenal function studies and be certain that the adrenal at this point is able to respond.
Dr. Dowd.
Do you recommend routine insertion of ureteral catheters for males, for large lesions, or as a routine? And the answer to all three of those is no. We do not recommend insertion of ureteral catheters ever, unless the surgeon, for his comfort of coronaries or soul or whatever, really wants them. Then we would be happy to put them in. I suppose that in a very active colon and rectal service such as Neil has, we average not more than 3 per year. There are rare times where it is of great benefit and we're happy to put them in, but it certainly is uncommon. The main reason for not recommending them is that studies urologically have shown that most injured ureters occur when there is an intubated ureter in the operative field. For you pick it up and denude it, and when the catheter comes out anywhere from 1 hour to 10 days later, that avascularized segment becomes a fistula. It is far more likely to be manhandled with a polyethylene catheter in it than if it were left alone. Obviously, you should know where your enemy is and note it anatomically, but there usually is too much manhandling if a catheter is in place. What measures would you do prior to? Anal surgery to prevent postoperative voiding difficulties. I haven't gone nuts, but the prostate is sort of analogous to the donut. Usually when we feel a small prostate, we assume that the hole in the middle is large. Whereas when we feel a large prostate, we assume that the hole in the middle is small. But just as with donuts, there's no federal law that says that a large donut can't have a large hole in the middle, or that the small donut can't have a small hole in the middle. Your history tells you more than the rectal exam. If the patient has had voiding difficulties with pain or with his anorectal disease before he came to surgery, he's apt to have trouble. It is most important in terms of prevention to have the patient void prior to the pre-medication for his anesthesia, so that if he comes to surgery with a relatively empty bladder, and if he's not overhydrated before the anesthesia has worn off, and if he didn't have true obstructive symptoms on your initial history, chances are great that you won't have to use any gadgets. But if you do, there are many of them. Keeping the patient comfortable but not so obtunded, helping him by standing him and letting him void in privacy, or propped up. Not with a cute nurse, because with a bashful bladder and a cute nurse, who can tinkle? Uricoline is a great help if there were no historic obstructive problems before. And finally, that evil weapon, the catheter, is probably the nicest thing you could do to the fellow, and far more trouble is averted by the use of a catheter early than delaying it 12 hours. If a patient has to be catheterized a second time, we would use a small indwelling Foley catheter.
Dr. Alexander?
This question is about digitalization. It brings a nice juxtaposition of the two kinds of cardiac problems. All of you are focusing on the patient who is in congestive failure. Really, that's not so hard to find out. The major reason why cardiac patients die, I think, after operation is perhaps because of the poor ventilation and things, which then produces and electrolyte problems and fluid overload, which produces cardiac arrhythmias. We know that we can prevent these fatal cardiac arrhythmias from occurring, and we can prevent this by monitoring them, because these fatal cardiac arrhythmias almost never come without warning, that there are certain clues the cardiologist or internist knows about, and if you only look for them, they're there. And these are arrhythmias that often require treatment. Often, because of my own personal interest, I begin to think about poor ventilation because I am first hung up on the idea that this patient has an arrhythmia, and I don't know why he's had it. There's no reason why he should. We're only really beginning to realize how often cardiac arrhythmias are produced by poor ventilation, by arterial hypoxemia. Whom do I use digitalis in? Those people who are in failure, those people in whom I want to prevent cardiac arrhythmias, are those people who have certain cardiac arrhythmias which digitalis is used to handle. I feel very strongly about this. I don't think the surgeon, by and large, has any place in giving digitalis, very frankly. This is a very dangerous drug with a mortality rate far higher than the operative mortality rate for cancer of the rectum, if it's given acutely. It's a very dangerous drug, a drug with a toxic therapeutic dose range that is very narrow. And if you think a patient needs digitalis, if it's at all possible, that's the time to call in your consultant. Unfortunately, the consultant may often not know a great deal about it either, because this isn't the internist's bag, so to say. Has never been terribly interested. He'd like to make the diagnosis of amyloidosis, but shepherding a patient through surgery is often something he doesn't pay a lot of attention to. I never use digitalis in older people for any other reason than the reasons I would use them in anybody. I think prophylactic digitalization, particularly by people who don't know a great deal about digitalis, is a very dangerous procedure. If the patient's in heart failure, fine, it should be used. It's no longer prophylactic. If the patient can meet the daily vicissitudes of outside life without needing digitalis, he probably can get through surgery. And there's nothing that the internist likes better than to come in post-operatively and know that this arrhythmia that he's faced with treating is not due to digitalis. And the only way he can know that is if the patient hasn't been on it. This partial digitalization, et cetera, is a very dangerous procedure. And I think patients need digitalis or they don't need digitalis. And if you monitor them closely, those who initially didn't need it, when they develop their need for it, they can be digitalized. But I urge you not to play with this thing. It's a very dangerous tool. And I suspect that I could do 100 appendectomies with a lower mortality rate than any one of you could digitalize 100 patients.
I'd like to ask Dr. Nicholson to take over.
I have a question as to what anesthesia do I prefer for rectal surgery. I take this to mean aniorectal surgery. I don't think there's anything better than what I've seen at the Mayo Clinic, namely the caudal transsacral. However, I've used the lumbar epidural single injection, and the problem with this is that you have to do it about 20 minutes ahead of time because the onset of anesthesia is slow. Using this, I think we have less post-operative voiding difficulties, and we certainly circumvent the post-lumbar puncture headache, which is a real problem in the patient having an aniorectal operation, which you'd like to have him up and around as soon as possible after the operation is over. Unfortunately, some of our patients get spinal because not all of my associates in our department share my enthusiasm for caudal. There's no question but that spinal anesthesia knocks out the mural sensibility of the bladder much longer than, well, it locks it out longer than any other type of anesthesia, so we have to expect more urinary retention problems after spinal, and we know that we're going to get a certain number, even though we use 22 and 24 gauge needles, of post-lumbar puncture headaches.
Thank you, gentlemen. And our thanks, too, to the American Proctologic Society for cooperation in recording and disseminating this material. Audio Digest Surgery is a bi-weekly service of the Audio Digest Foundation as a non-profit subsidiary of the California Medical Association. All material in this program is copyrighted and duplication is prohibited.